Welcome. I'm Troy Donahoo, an endocrinologist and weight management specialist with Kaiser Permanente, Colorado, and the University of Colorado. And with me today is
Lisa Van Wagner. I'm a postdoctoral fellow from Northwestern University in the Departments of Preventive Medicine and the Department of Gastroenterology and Hepatology.
And today Lisa's going to tell us about an interesting study that she has just completed and presented here at the American Heart Association meeting.
Great, thank you so much. Well, we presented a study called Nonalcoholic fatty liver disease and subclinical atherosclerosis from the CARDIA cohort study. And a couple of things to know. When we use the term non-alcoholic fatty liver disease, we're actually talking about a spectrum of disorders that ranges from simple fat in the liver to fat plus inflammation entitled non-alcoholic steatohepatitis, or NASH, that can then lead to cirrhosis and liver failure. Patients who have NAFLD are actually more likely to die from cardiovascular disease than they are from liver disease. And there's been a body of literature that's come out saying that NAFLD may actually be an independent risk factor for the development of cardiovascular disease apart from common metabolic comorbidities. And so what we did with the CARDIA cohort study is we looked at cross-sectional associations using data from the year 25 exam to see if there was an independent association between NAFLD and subclinical atherosclerosis, and then to see what factors might account for that association. So during the year 25 exam, all the CARDIA participants, and for those who are not familiar with CARDIA, CARDIA is a large longitudinal cohort study that in the mid-1980s, just over 5,000 black and white young adults were recruited here in the US across 4 study centers. There's been about 8 examinations with 25 years of follow-up. And during that most recent 25 exam, all the CARDIA participants had CT scans done of both the liver and the heart. And what we did is we looked at cross-sectional associations between the presence of fat in the liver and calcium scores in either the coronary artery or the abdominal aorta. And what we found is that although there is an association between NAFLD and subclinical atherosclerosis, that association is highly attenuated once you control for any measures of obesity, whether that's body mass index or something called visceral adipose tissue, which is actually a dynamic endocrine organ that secretes a variety of inflammatory factors that leads to insulin-resistant atherosclerosis. So no matter what you did, that effect of NAFLD was attenuated at that point. So we concluded that based on the current study that there does not appear to be an independent association between NAFLD and the presence of subclinical cardiovascular disease, at least in the CARDIA cohort.
Well, as a practicing physician, I'd hate to just take away all those patients I have who have NAFLD and just say your risk isn't any greater. Do you think that actually really does go for the entire cohort, or there may be some subgroups that we're missing because of your study design that might really be higher risk, that we should be more aggressive with their lipids or other cardiovascular risk factors? Absolutely,
that's a wonderful point. So if you remember when I said we use the term NAFLD, we're actually talking about a spectrum of disorders. And there's that portion of NAFLD, that necroinflammatory form, that NASH. That is a very active inflammatory condition that likely possibly plays a role in the development of cardiovascular disease based on the body of literature that is out there. And so identifying that subset of patients with NASH is probably very important in addressing their cardiovascular risk because they are likely at higher risk. Now, unfortunately, the CARDIA study cannot answer that question because the only way to distinguish between simple fat in the liver and NASH is to biopsy the liver. And epidemiologic studies can't biopsy thousands and thousands of patients.
But in trying to translate this potentially to clinical medicine, who really should be having a biopsy that then we would know that this is a risk factor we should be looking more aggressively at?
Absolutely. So the American Association for Liver Diseases has published clinical practice guidelines based on this issue, and they recommend that patients who are over the age of 40 and who have either evidence of type 2 diabetes or pre-diabetes or insulin resistance should be biopsied in order to see if that necroinflammatory form of the disease is actually present. Those are the patients that, as internists or primary care physicians, that really need to be referred to a hepatologist for consideration of biopsy. And then if the biopsy comes back with NASH present, those are the patients as hepatologists that we refer to endocrinologists as yourself in order to more aggressively manage their diabetes, or to cardiologists as well to more aggressively manage those lipids.
So once we in either primary care or specialty care, non-gastroenterology, see somebody that we think might have NASH and meet your criteria, should we refer them directly to a gastroenterologist, or is it worth trying to treat them with other medications or even weight loss first? So kind of what's our next steps? Do we send everybody to you, or should we work on things first before they go for a liver biopsy?
So that's a wonderful question. The portion of patients that definitely needs to be biopsied is anyone who has any sort of abnormal liver tests. As far as treatment, the only proven treatment we have for the disease condition at this point is weight loss. But it is important to risk stratify those high-risk patient populations. So I would say that anyone who's in that high-risk group, age over 40, has diabetes, should be referred to a hepatologist for consideration of liver biopsy. And anyone who has abnormal liver enzymes should also be referred, mostly to rule out other forms of liver disease that could be contributing to their condition. As far as medications that we have available to treat the condition, there's a large trial that came out about 1.5 years ago called the PIVENS trial, published in New England Journal of Medicine, looking at vitamin E and pioglitazone, which is an insulin sensitizer that I know you're well aware of, to treat diabetes and to see if that had an effect on the NASH disease state. Vitamin E was effective in actually downgrading the NASH severity. Pioglitazone did not meet the primary endpoint in that trial, so the only drug as of right now is really questionable whether vitamin E plays a role in treatment.
And then long term with these patients, if, you know, obviously looking and treating for excess cardiovascular risk, but also other long-term risks as far as the non-alcoholic fatty liver disease or the steatohepatitis. Do they have other risks that we in either primary care or specialty care outside of GI should at least have in our mind to make sure that they're being followed appropriately? Absolutely.
So there's been recent literature that's come out saying that patients who have NASH as a cause of cirrhosis are at increased risk of developing hepatocellular carcinoma. So anyone who has cirrhosis as a result of having NASH absolutely needs to be followed by a hepatologist and needs to have regular screening every 6 months to look for hepatoma. We know that patients who have NAFLD, the umbrella category NAFLD, have an increased mortality, mostly from cardiovascular diseases, as I mentioned previously, and so that's the primary thing that we need to be focusing on as far as risk reduction.
Well, thank you very much. It's been a pleasure.
Thank you for your time.